All right, it's just a few minutes after the hour. Hello and welcome to all of you from all corners of the continent and beyond. Today is a special day. It's the 50th COVID-19 special session that we have. For those that love cricket and other sports, you could call this a half century. And in this special session, we really want to talk about a key important subject with regards to the COVID-19 pandemic. Today, we are focusing on how genomic sequencing of SARS-CoV-2 continues to provide valuable insight into this ever-changing variant makeup with regards to COVID-19 pandemic. We all know that millions of SARS-CoV-2 genomes have been deposited in the GSA initiatives. And we also know that largely by design, clinical laboratories hardly or arguably, they don't really aim to save many of the epidemiologic or public health testing. And many of the clinical labs do not contain in-house sequencing technology. We also know that the pandemic has been with us. I think it's almost 2 years now, and it seems it will be with us for a while. And therefore, there's need for clinical laboratory staff and personnel to really be in here to lend expertise, share specimens, resources, and partner with surveillance labs, academic labs, and sequencing course in order to assist the SARS-CoV-2 epidemiologic sequencing efforts. And in acknowledging the efforts of the Africa PGI in trying to accelerate SARS-CoV-2 sequencing in Africa, I'd like to call upon our presenter for today, Dr. Sofonias K Tessema, who is the program lead at Africa PGI, the Institute of Pathogen Genomics, Division of Laboratories, Service Systems and Networks at the Africa Centers for Disease Control, Africa CDC. He will outline some of the lessons, maybe also some of the best practices, strategies that have been employed in accomplishing these goals, and also discuss some of the challenges with implementing and maintaining such an important program for our continent and obviously beyond. Ladies and gentlemen, let me remind you that this is a 1 hour long session that will be made up of the presentation first, and then we'll take questions and comments immediately after the presentation. I'd like to remind you to put your comments and questions into the chat box, and we shall attend to them immediately after. A kind reminder again that we have French language interpretation available. So for those that are on your PCs, you will find a globe, a sign of a globe. Please choose either English or French in order to hear any of the languages of your choice. Let me hand over to you, to Dr. Sofonias, to take us through today's session. Over to you, Sofonias.
Thank you so much, Anafi, for that introduction, and thank you so much for the invitation to talk about some of the work that we've been doing in accelerating SARS-CoV-2 sequencing in Africa, and then also to highlight some of the challenges and the lessons that we've learned, and how do we improve the efficiency of sequencing to use this data to inform public health decision-making or to inform the decision-making in our outbreak response. I'll turn off the video to save some bandwidth. My connection is not very stable. Please bear with me. So my name is Sofonias K Tessema. I coordinate the Africa Pathogen Genomics Initiative at the Africa CDC and the Division of Laboratory Systems and Networks. So the work that I will be presenting today is a collaborative work, or I can say joint work between ASLM and Africa CDC in strengthening SARS-CoV-2 sequencing in Africa. And some of the challenges that we faced, most importantly, the lessons that we've learned across the process. So my presentation will focus on explaining a little bit about who we are what we do at Public Health Pathogen Genomics in the Africa CDC. When did it start and where are we now? The work that we've done jointly with ASLM in accelerating SARS-CoV-2 sequencing in Africa. And what is the progress, what are the challenges and the lessons that we've learned in the past 1 year? And I'll try to summarize my presentation at the end. So I'll go first about the public health pathogen genomics at the Africa CDC. The Africa CDC was launched in 2017. And 2 years later, or a year later, Africa CDC jointly with ASLM started understanding the challenges and gaps in the continent for the implementation of genomics and bioinformatics. What are the gaps? What are the needs? And how do we address that? So for 2 years, there was a lot of mapping that has been conducted to understand the major challenges in the continent. By January 2020, we conducted a continental consultation on pathogen genomics. That was, all of this work was pre-COVID. So a few months later, COVID actually showed up in Africa and it was reported. So what do we found in our assessment? Our assessment pre-COVID found limited infrastructure and skilled workforce, both in the lab and data side. Enabling mechanisms are not in place, lack of policies and frameworks, leadership and coordination, several supply chain cost and custom related challenges that we have identified in our assessment and continental consultation. Our findings somehow summarized in this publication. You can find more details. But what I would like to show you here is this is a pre-COVID map of presence of sequencing, NGS sequencing equipments in Africa. As you can see, there are just three things that you can see. Big bubbles, that means more sequencing equipments. Small bubbles, little sequencing equipment. And no bubble means there is no NGS sequencing equipment. So it really shows very sporadic capacity in the continent. This is between 2018 and 2020. So the latest data is up to 2020. So if we have such a gap in the continent, this gap in capacity, some have some level of capacity, others do not have any capacity, others are in the middle, in between. So then 2 years later, the Africa CDC, from its launch, launched an institute called the Africa CDC Institute of Pathogen Genomics to address these gaps, the gaps that I just showed you. But 2 months later, COVID-19 pandemic was reported in Africa. And then since then, all our focus has been on the COVID-19 outbreak. We've been advocating early on to accelerate genomics-based surveillance for COVID-19 response in Africa before the discovery of variants of concern. And in 2020, we launched this comprehensive initiative called the Africa Pathogen Genomics Initiative, which was designed to strengthen the whole system and capacity in the continent. This initiative was launched in partnership with several partners in the public, private and philanthropic sector. The initiative had 5 components at its launch. The first one is to strengthen the Africa CDC Institute of Pathogen Genomics, to establish a continental network and capacity, to address the workforce gap as NGS Academy, as you can see, in the laboratory, bioinformatics and genomic epidemiology space, data and the data architecture, both in the governance as well as sharing side, advocating for political regulations, policies to be in place, as well as addressing the technical challenge of data sharing. And then supporting and coordinating high impact genomic use cases. That's really to show genomics can actually add value for the public health surveillance system in Africa. So this initiative, as I said earlier, have been focusing on accelerating SARS-CoV-2 sequencing in Africa. So I'm going to show you what we did in the past 1 year, specifically in 2021. By early 2021, we set a target at the Africa CDC in collaboration with ASLM. The first one is to operationalize the sequencing network and to support the sequencing of up to 50,000 SARS-CoV-2 genomes in Africa.
Dr. Sofonias,
Yes?
Sorry to interject. The interpreter is kindly asking if you can slightly slow down so that she can catch up. Thank you.
Sure. The second one is to support member states with limited or no sequencing capacity through specimen referral system. We had a target of supporting 35 countries and 20,000 samples. The third is to support training of up to 100 candidates. So we've been operating using this network, the network that you see here, the Africa CDC and WHO Afro COVID sequencing network. We established this in collaboration with WHO Afro. The network has 3 layers. The top layers, what we call specialized genomics and bioinformatics centers. The middle layer, the regional sequencing hubs. And then the bottom layer, the national sequencing laboratories. So each layer has specific functionalities. I will come into that. So the top layers, they are expected to support capacity building and training of the regional and the national laboratories, support high throughput sequencing service, and quality assurance as well. The middle layer, what we call the regional laboratories, they support their own country and at least 3 countries in their region. And the bottom layer is the national level laboratories. These are designated by Ministry of Health to support sequencing in their own country. So as we started operationalization of this network, we developed a simplified strategy because we are beginning and we are in the middle of a pandemic. So we thought we can have a more simplified strategy to operationalize this network. So the first strategy is to leverage and strengthen the institutions that already have some level of capacity. And the second strategy is to expand and democratize sequencing. This is basically, as I showed you earlier on the map, there are countries that do not have NGS sequencing capacity. How do we expand this sequencing to be available to public health institutions in member states that do not have it earlier? And the third strategy is how do we network between the beginners labs, between the labs that do not have sequencing capacity and the labs that have advanced and moderate level of capacity. So we've been operating with this 3 strategies for 2021. So I'll just go through a bit of what have we achieved in 2021. Our sample specimen referral network, this is cross-border specimen referral from countries that have no or limited sequencing capacity to the regional or the specialized sequencing laboratories. 36 member states sent samples to these regional hubs, and a total of more than 24,000 specimens have been referred in 2021. And the average number of days from the sample pickup to delivery has been 3 days. We faced some challenge in this sample referral process. I'll come back into the challenge later. In terms of supporting the laboratories, leveraging and strengthening the regional hubs, because some of these regional hubs have limited capacity, some have advanced capacity. So we've been supporting these regional sequencing hubs to conduct SARS-CoV-2 sequencing. The whole objective of this process is how do we accelerate sequencing? By 2020, when we end 2020, there were only 5,000 genomes in the continent, which was less than 0.5% of the global average. So in order to strengthen the overall sequencing ecosystem in the continent, we've supported the sequencing hubs and the regional hubs that you see here on the map. We distributed about 1.7 million in a sub-award to support SARS-CoV-2 sequencing in these labs. We've been supporting these labs with reagents, and then also about 12 sequencing equipments have been distributed to these member states. This is really to strengthen the overall sequencing capacity and equipping these labs with the type of equipment that they need in order to be able to support other countries, in order to be able to sequence the samples that they are receiving as part of the sample referral network. We've also been working to democratize and expand sequencing into national public health institutes and national reference laboratories. The countries that you see here are national level laboratories that we've supported in 2021. 14 member states, more than 35,000 reagents have been distributed, and 12 sequencing equipments have been distributed in 2021. It's not really to say that this is sufficient, but this is to show the progress that we've made in 2021. The other area of focus for us in terms of supporting SARS-CoV-2 sequencing in Africa is workforce development, making sure that well-trained individuals are available at national, regional, and specialized centers. So in collaboration with some of the reference laboratories, we conducted 6 trainings, 4 hands-on and 2 virtual trainings, and about 117 trainees were trained in 2021. This covered 44 member states in Africa. For those countries that are referring specimen from their country to the reference laboratories, we've also conducted training on infectious substance handling, packaging, and transport in collaboration with IATA. We conducted 3 trainings, and 39 trainees were trained from 34 member states, as you see on this map. All these trainings are either, to be able to package the samples properly, to ensure samples are packed and shipped to the reference laboratories in good condition, so that we get high quality sequences from the samples. So this is what the Africa PGI partnership, the Africa CDC in collaboration with ASLM has achieved in 2021. But several other initiatives at national and regional levels are also supporting SARS-CoV-2 sequencing in Africa. We're not the only ones supporting SARS-CoV-2 sequencing. So what change do we see? What results did we achieve with this support? So as you can see here in the figure, the total number of sequences in 2020 was merely like 5,200. But in 2021, that increased by 12-fold to 60,000 sequences. We set a target of 50,000, but we passed that target in October 2021. If we look at the spread of the sequences, where are these sequences coming from? In 2020, about 20 countries had sequences, and of which only 6 countries had routine sequencing. But in 2021, at least 50 member states have sequences generated and shared, and at least 25 of these member states had routine sequencing. And this sequence data has enabled the continent to monitor the spread of variants of concern. As you can see here, it's a temporal spread of the variants of concern in the continent. There was a beta wave, followed by the delta wave, and what is going on now, the Omicron wave. So with this expansion in sequencing and the acceleration of sequencing in Africa, what are the challenges and what are the lessons that we've learned? I think the key message that I have in this presentation will follow this part. The first one is really understanding the overall genomic surveillance ecosystem. So based on my understanding and the experience that we've seen in the past year, there are 4 key areas, key components of the genomic surveillance ecosystem. These key components, they need to be integrated and talking to each other in order to have data that can actually inform public health decision-making. The first one is the sampling and the sequencing strategy, which identifies the purpose of the sequencing, and then also the type of specimen, the specimen number, the frequency, the timing, and the representativeness and informativeness of the specimen. The second one is there should be a laboratory system, which is well equipped in terms of personnel, as well as infrastructure, to ensure that data is generated in a timely manner, as well as high quality data is generated to inform public health response system. The third component is the data systems. Once the data is generated, the data must be analyzed and interpreted in order to make meaningful information for the public health decision making. And the fourth is, once data is generated, it must be utilized. It must inform the public health decision making. I think in order to have a functional genomic surveillance program, all of this at a country level must be coordinated to each other and linked to each other and talk to each other so that the data that we have is actually meaningful and inform our public health decision making. A little bit going in depth into what I was showing now. What does it mean to us when we look at those four components? The first one is the specimens should be collected appropriately with proper type of metadata. The clinical information and the specimens should be collected and linked, and then specimens must be stored at appropriate storage condition so that we can have high quality data. Then the extraction process should also be conducted in a quality controlled way to avoid contaminations, and then also to maintain the integrity of the sample. The third step is the PCR, the lab side. The lab component of the sequencing must be done in a standardized way, as well as maintaining the quality of the samples and preventing contaminations of samples. Then once the library is ready, I think the next step is the sequencing, whatever type of platform is available, really to do the sequencing in a cost-effective and efficient way. And once the sequencing data is out, it must be analyzed in a timely fashion. So that timely analysis is really critical to produce data that can be interpreted and reported to the public health decision makers. Then, we can have a public health decision making informed by the genomic surveillance data. So unless we have a clear system that's created across these dots, unless we are able to connect all these dots clearly, the data that we get at the end may not be able to inform public health decision making. So I think this is one of the key lessons when we think about genomic surveillance. I think it starts from the field where the sample is collected, and from the sample transportation and storage, collecting appropriate metadata, and then conducting all the lab work in a standardized protocol, quality maintained, and then data generated timely, analyzed timely, interpreted timely, and reported for the public health decision making in a way that makes sense and in a way that can be utilized by the system. So what are the key considerations? I will not go into too much into the detail, but what are the key considerations and lessons and the sampling and sequencing strategy? That's really the key for sequencing. Before we start sequencing, we need to know the purpose of the sequencing. Why are we doing the sequencing? We need to define the objectives of the sequencing. That really helps to select samples carefully, to design our sequencing process very carefully and identify proper type of samples that can actually inform the public health decision making. So the sampling and the sequencing strategy should be developed based on the local epidemiological context. Currently, what we see globally, there are two types of approach that have been employed. One is representative sampling and sequencing is designed to monitor and detect new variants of concern as they emerge. And the second one is sequencing to investigate different cases. For example, it could be a vaccine breakthrough infection, or outbreaks, local outbreaks, or it could be clusters of infection or unusual events that we see in the COVID-19 outbreak. So really the first step is to define the purpose that helps to design the overall sequencing strategy in the country using the local epidemiological context. The second key lesson that we've learned is sample quality is important. I think the quality of the sequence data starts with the quality of the sample. So high quality samples tend to provide high quality genomes. That means the genomic data becomes more useful. Samples must also be accompanied by appropriate clinical and epidemiological data that will really help to inform the interpretation of the genomic data. Genome sequences by themselves do not give us the information that we need to inform public health decision making. So all associated metadata or associated clinical data should be collected. It should be complete and then also linked with the samples or the specimens. We've been working with phage and we have templates for this metadata. What are the key information that should be collected to support specimens for sequencing? So those informations can be accessed in these links. The other challenge and lessons that we've learned is as we try to move samples across borders. I think if a country is planning to design a sequencing strategy, but using a facility outside of the country, I think the following must be considered early on to avoid delays, material transfer agreements, import and export permits, understanding the courier efficiency, which couriers are available to move samples, and the connectivity, flights, dry ice and packaging materials. And all of this must be considered before we send or we prepare the samples for shipment, because this can cause an extra delay. And a specimen, for example, that was collected in January might be shipped in March if we are not pre-planning about all of these requirements to move samples from one country to the other. I think all of these considerations, if we plan them ahead, I think we can reduce the time that takes to generate data, which means the data that's generated can actually inform the public health decision making. Once the samples are picked, that means once all of these essential informations are in place, the packaging materials are in place, material transfer agreements and import and export permits are in place, it takes about 4 days. So the majority of the delay is not from pickup to delivery. The majority of the delay is pre-pickup, making sure that all of these regulatory and logistical issues are in place. So the second area with the lessons that we've learned is in the laboratory systems. I will keep it high level here. Genomics infrastructure is key. We have limited genomic infrastructure capacity in the continent. We are trying to expand that. Sometimes the turnaround time is highly affected by the lack of those infrastructures. Well-trained workforce is key in the laboratory systems, workflows and information systems. We should be able to have some sort of tracking mechanism where we appropriately link a specimen with the clinical and epi data, and then also with the genomic data. All these three should be linked and should be tracked. Quality assurance is key. The data that we generate must be quality assured, and then also always keep an eye on the turnaround time. This turnaround time is what makes the data useful or not. If, for example, if we are generating a data for specimens that were collected in October today, it will show us there is no Omicron, which is not really accurate. So I think time is really an important component of the whole system. But time cannot only be just improved by the laboratory capacity. Each component, from the sample collection to the lab, to the data, to the analysis and interpretation, all of that is time sensitive in order to make the data more useful. In the laboratory system, again, key challenge that we faced is the lack of trained personnel and throughput of equipments and lack of automation. It takes time for sequence data to be generated. Turnaround time is affected by all of these factors. The global demand and supply chain disruptions affects our laboratory efficiency of our laboratories. I think forecasting, to be able to forecast the needs of reagents, to be able to adjust to the global demand and put orders ahead of time, it really helps in terms of addressing this supply chain challenge. Quality assurance, there was no EQA panels for genomics and bioinformatics, at least last year. that has also been a challenge to conduct EQA for SARS-CoV-2 genomics and bioinformatics. And sustainability is also key. When we design the labs, or when we think about the lab systems, how do we ensure that these labs are designed not only just to respond to the current outbreak, but to prepare us for future outbreaks and to support sequencing for other pathogens as well. In terms of data, again, very similar to the lab side, we need to have proper data infrastructure in place that can support the type of data that is generated by sequencing. It requires a well-trained workforce to analyze, to process sequence data. Workflows and data standards are key. And quality assurance of the data is also must be done. There should be quality control on the data to ensure that the generated data is accurate and high quality to inform decision making. Again, on the data part, the data must be analyzed within a short period of time so that the data becomes available to inform decision making. But what are the challenges that we are facing in this side of sequencing? Trained personnel in bioinformatics is the shortage of this highly trained personnel in bioinformatics is a big problem in the continent. Data sharing, where turnaround time is key. It's not just only sharing, but it is timely sharing the data to use it for decision making. When I say data sharing, it's from the collection of the sample to the sharing of the data until the data becomes available for public health decision making. As you can see here on this graph, you can see in Europe it takes about 17 days from collection of the specimen to sharing the data, but in Africa it's almost 2 months in average. So you can see here in this graph the range of turnaround time from collection to sharing in many, almost in all African countries that have sequence data. So data must be shared in order to be utilized, not only just to inform an outbreak response at a country level, at the national level, but also at regional, continental, and global levels. Data standards and workflows have been also a challenge. Different labs have different data processing workflows. So standardizing that has been a challenge in the past year. So the next area which I would like to focus a little bit, and I would like to leave you with that message, is data utilization. Sequencing for the sake of sequencing will not inform public health decision making. Sequencing must be designed in order to inform or improve our public health decision making process. So there are key considerations that I think are important for data utilization. The first one is representativeness of the data, representativeness of the sample. What are we sequencing? Which must be able to address why are we sequencing. I think representativeness and the sampling strategy, the sequencing strategy is really key. Before we put a sample into a sequencer, we need to think about how does that help? How does that add value into our outbreak response? Because this is a very expensive process. So the best use of our resources is to ensure that every sample that's sequenced actually provides information to the public health decision-making process. Most importantly, in Africa, this question is really critical because we have very limited capacity. Globally, if we compare the global 8 million data, now we are at around 80,000. So we are generating only 1% of the global sequence data, and we are sequencing only 1% of the total cases. So the selection of the samples must be informed by very clear questions, very clear purpose to use this data to inform decision-making. Completeness of data and completeness of metadata. When we collect a specimen, the specimen must be accompanied by epidemiological and clinical data that can actually help to interpret, help to analyze and synthesize information out of the sequencing data. As I said earlier, we have some templates which can be used, but it's really about thinking about when we start thinking about sequencing of a specimen, do we have the necessary informations? Have we collected the clinical data? Is it accessible to us? Is this complete? I think those are the kind of questions that we need to ask, which at the end determines the utility of the data. Quality is key. When I say quality assured data is not just in the lab or in the data analysis. It should be from the sample collection to the final analysis process. All those steps should be quality assured or quality checked, because the quality of the sample determines the quality of the library. The quality of the library determines the quality of the sequence. The quality of the sequence determines the quality of the data that we have. Therefore, if we have a lot of low quality sequences, it will be very difficult to make sense of that data and to use it. So data utilization is really dependent on the quality of the whole process, the whole workflow that we have. Time is another important factor in this ecosystem. When we think about time from the collection to utilization of the data. In order to know how our outbreak is progressing today, we should have information about the past week, not about the past months. So it's really important to have timely data. So a lot of this might be related to capacity, the turnaround time. A lot of it might be related to regulatory challenge that we are facing. But I think sequencing the latest specimens, the latest samples, it really helps in terms of interpreting the data and then also understanding the current status of the outbreak. So at the end, genomics shouldn't be operated in silos. It should be linked with the overall public health surveillance system. That is actually when we are able to get all the clinical and epi data. And then also that's only when genomics become component of the bigger health surveillance system or public health surveillance system. That's really when it can actually inform public health decision making. These are some of the key considerations that we've learned in the past year. There might be more for sure, but these are some of the key areas that I have identified. So how can we build on the efforts for pandemic preparedness and disease surveillance in the future? As you've seen, Africa CDC, in collaboration with our Africa PGI partners and ASLM, we've been trying to expand sequencing capacity in the continent. But this sequencing capacity should also be used in preparedness and disease surveillance. So I will just leave you with questions. Genomics has potential for other pathogens beyond COVID. For example, it could be detection of new outbreaks, emerging and re-emerging diseases, in the surveillance, monitoring vaccine efficacy, transmission events and reservoirs of infections. You can see emerging and re-emerging diseases as well as endemic diseases across the board, from malaria, TB, HIV, foodborne diseases, as well as vaccine preventable diseases. So it's really about when we think about genomic surveillance, it's not just only about COVID. How do we create a system that can actually support beyond COVID at the national level? So this also leaves the question that is having more core systems, core laboratories, does that really help in terms of addressing some of the challenges that I have listed earlier in improved utilization or in better utilization of genomic data for public health decision making? With that, Africa PGI, the Pathogen Genomics Initiative at the Africa CDC, which is currently being coordinated in collaboration with ASLM, we aspire to create a platform for partnerships to effectively implement and translate pathogen genomics into public health decision-making process. We are working in the coordination area, coordinating multiple partners and coordinating the capacity building, the training, and the implementation of use cases. We are also encouraging collaborations between laboratories, between institutions within and outside of the continent to strengthen genomics and bioinformatics capacity. And then this will require a bit of commitment to actually strengthen the overall genomic surveillance system in the continent. With that, I would like to acknowledge all our Africa PGI partners, the Bill and Melinda Gates Foundation, Illumina, the US CDC, Oxford Nanopore Technologies have been supporting us in the past year and are supporting us even now as we strengthen the continental genomics and bioinformatics capacity. And we are working closely with a range of specialized centers, national and regional laboratories across the continent. So with that, thank you so much, and over to you, Anafi. Over.
Thank you very much, Dr. Sofonias, for the wonderful presentation. And we can see a lot of questions in the chat. Keep them coming as we are about to start our Q&A segment. I also call upon the ASLM and Africa CDC team working in the PGI, Edwin and company, to also help maybe just answer some of the questions in the chat as well. Right, let me take the first few questions that came through, and I think maybe before I take these, I think clearly what we can see from the presentation is, I think the common challenges that we face also for clinical laboratories as well. But I want to just pick three key statements that you used. You said time is of essence. I think within that whole cascade from sample collection up to reporting. You also said we don't want to sequence for the sake of sequencing. You know, we need this to be very useful, and we've always talked about how usable the results are. And genomics should not be operated in silos. And I like one of the slides that you put at the end. And this gets everybody interested. So clearly, one of the first question is, are there any plans for Africa CDC to support, and this is coming from Eric Opio, are there any plans for Africa CDC to support the sequencing, support procurement of genome sequencing machines? And there were quite a number of questions which really talked to this. So I've picked this as a representative one. You can take that one first.
Thank you so much for the question. The Africa CDC, through the Africa PGI partnership and in collaboration with ASLM, we've procured 30 equipments in 2021 and distributed it to member states. And we also have plans to continue and support member states with sequencing equipments. But as I said earlier, with that strategy, in some cases it's to expand existing capacity. In other cases, it's to have, for the first time, to establish NGS sequencing capacity. Yes, we are doing that, and we'll continue to do that as based on the resources that are available for us. Over.
Thank you. Along the same sort of wavelength, Irwan Piru says, thanks for this interesting session. He understands the reagents for most NGS systems are challenging, especially the very short shelf life, insufficient distribution network. How are you solving this problem?
Yeah, so this is one of the major challenge that we are having, that we are seeing now, and we faced in 2021. I think what we need to consider is globally, 8 million sequences have been generated in the past 2 years. What does that mean to the global supply chain system for sequencing reagents and sequencing equipments, or even the raw materials that are needed to prepare that? So there is a global demand, a very high global demand. Mm-hmm. So we are operating in that era of very high global demand. So to address this, we have partnerships with the private sector. The sequencing equipment and sequencing reagents manufacturers, we have a relationship with that. They are parts of the Africa PGI partnership. So they are supporting and prioritizing this, some of our countries, some of the countries that we are supporting as part of the Africa PGI partnership. But what that means is that it doesn't mean that we are facing any challenge. We are facing delays. Countries are facing delays. It will require further discussion, further engagement with the suppliers to improve the overall supply chain system. in Africa. I think the other challenge is to be able to have a predictable and forecasted need in terms of sequencing reagents. A lot of these labs some are new to sequencing, and some are in that space for a while. But to be able to determine how many reagents do I need and how long it takes me to actually access those reagents in the supply chain system, I think having predictability and having forecasting capacity is really critical. So we are working in that kind of a mechanism, trying to create, for example, scheduled shipments of reagents to some of the laboratories, so that sequencing is not interrupted because they don't have reagents. So I think that forecasting capability will really help to change a lot of, to address some of this challenge, at least a chunk of this challenge. But still, it requires a lot of engagement and improving the overall supply chain system in the continent. Over.
Thank you for the elaborate response. Very helpful indeed. I think along the same lines, I think there are questions like how, I think this is coming from Anik, what is the criteria that you use to select the countries that are being supported at the moment?
So the current SARS-CoV-2 sequencing network that was established jointly with WHO Afro is based on those strategies that I said. How do we leverage the existing capacity in the continent instead of trying to start from scratch? Yeah. How do we use those capacities? Because we are in the middle of an outbreak. Starting from scratch will take a longer period to establish the capacity. So what you see as specialized centers and as regional hubs, they are selected one based on the existing capacity, two based on regional distribution. You can see we have representation across all the 5 regions of the Africa continent, because the Africa CDC operates through the regional collaboration centers. So all the 5 regions, North, East, Western, Southern, and Central Africa, are all represented with regional hubs. And the number of regional hubs are also proportional to the number of countries in the region. So equity is another criteria here. So equitable distribution of capacity across the continent. The other selection criteria is strategic directions of the Africa CDC, regional collaboration centers. We have 5 regional collaboration centers in Africa, so strengthening those regional collaboration centers was also considered. And in terms of how do we see it forward, I think with COVID, we are seeing genomics is becoming the center of the response, the COVID-19 response. And it shows that genomic surveillance is key for public health decision-making. I think we'll continue to expand as resources become available so that our reach actually is much more bigger than what we have now and where we are today. Over.
Okay. Thank you very much. I think one of in your previous response, you sort of touched also one question that was raised by Kezaf Mohammed, who wanted to know the efforts of the public-private partnerships. I know you touched it a bit. Do you want to sort of single out any major ones that are coming to your mind quickly?
Yeah, I think PGI by itself is a public-private partnership. We have the public sector, we have the private sector, and then we have continental organizations such as ASLM and Africa CDC in it. So I think what's really important here is where we were at before 2 years in terms of genomic capacity and considering the gap that we have in the continent that needs to be filled. I think it will require collaboration across sectors. Across organizations in order to be able to address that. So the problem is much more bigger. So we actually need to bring more partners to support PGI and expand capacity across Africa. Over.
Thank you again, Sofonias. I acknowledge we have about 8 minutes to go. The questions are many, so I'll try to pick according to the general themes that are coming through. Hoping that some of our colleagues can also address some in the chat. Moving on, I think one of the key areas that you touched, which is very important, was the issue of data analysis and eventually reporting. And I find this question from Oscar Mwashuia very interesting and quite practical. He says, what are the mechanisms, what mechanisms has the Africa CDC put in place for collecting lab testing data from the sites that perform the sequencing? What is the role of health authorities in authorizing a release of such data?
So data sharing is just one of the challenges. I think there was also some questions around data governance. The way how we see it is there are two systems that needs to be in place to address this data sharing issues and timely data sharing. The first one is, I think, data security. Countries own their data, and when they share, they should be able to share with the organizations that also support, public health in the continent. But in order to have that data security, there should be a clear data governance and data policies in place. I think we are working towards that, towards putting in place governance policies and guidance in terms of how do you share that data. So addressing the political side of the data. When you share the data, who you share with, why you are sharing your data, and who has access to that data. I think clear definition of those components of data sharing is critical. The second one, where we are also struggling with, is the technical side. How do we share this data? What are the technical mechanisms, the technological mechanisms of the data sharing? For example, if I receive 100 gigabytes of data today, how do I have the mechanism to handle that? Do I have the mechanism to securely store that and analyze it and then also use it to inform continental decision making? I think that's the area that we are actively working on. How can we develop a technological solution that can enable member states to share their data in a more secured way? And this data is not just shared for the sake of sharing, but to be analyzed and synthesized and inform decision-making at national, regional, and then also continental level. I think putting that system in place is critical, but we are at a very early stage towards that, towards creating a real-time data sharing mechanisms supported both technologically as well as with the appropriate policies and governance in place.
Mm-hmm. Yeah, thanks again for the comprehensive response. Great steps forward indeed. I think maybe also moving on around the same issue of sharing, maybe beyond data. I also find one question coming from Iruka Okeke, quite also very relevant here. She says, does Africa CDC have biorepository arrangements or requirements that are eventually sequenced? She's looking forward as well.
Sorry, I didn't clearly understood the question.
She says, please, does Africa CDC have biorepository arrangements or requirements for samples that are eventually sequenced?
So this is, I think, I'm not very clear with the question, but in terms of biorepository, there is some work that's being done as part of the laboratory division to improve capacities in biorepository, sample management, sample collection, metadata collection, and all those that are associated with biorepository. But specifically on the sequencing side, we don't have that yet. So this is something that needs to be developed depending on the type of pathogen. or the type of use cases that we are going to implement across this Africa PGI network. Over.
Thank you. I know the time is not on our side, but there were quite a number of questions that came with regards to quality. As usual, wherever there is testing, I think everybody is interested in knowing what are the mechanisms that have been put in place. So there are a few questions. One is from Jafar Sufi. He says, is there any plan for alternative ways for EQA? Maybe you could just use that one to also just speak to the issues of quality in general. Possibly also in your responses, we close, include any efforts for training. I know there's one question that also came from Nomtebo. Pongwai. Thank you.
Yeah, so I think I have a lot of my colleagues in this call who are experts on the quality side who can better answer this. What I can say is, we are working with ASLM to develop a quality assurance framework for the overall genomic laboratories, as well as in the bioinformatics side. And EQAs are becoming available now. So external quality assurance will be possible, I think, this year. So I think I will just say, look into those QA framework when they become available. There's an active work that is ongoing on that side. So we'll have it on both Africa CDC and ASLM website when it's available. This is a guidance on the overall quality assurance system for genomics and bioinformatics. Over.
Thank you very much. As usual, 1 hour flies past when you are discussing important subjects. Also want to thank many of our colleagues who are responding to some of the questions that are in the chat, acknowledging Blessing and team for responding to some of the questions. I just want to give the next 30 seconds to Dr. Sofonias Tessema to just summarize this session and the way looking forward.
Thank you. Thank you so much. First of all, thank you for inviting me for such an interactive session. So many questions. I can be followed up by email to answer some of the questions, or our team, both from the ASLM and the Africa CDC side, are available to answer any questions that you have on this work. I just want to say this is a work in progress. PGI only turned 1 year this year. So there is a lot more to be done. There's a lot more gap to be filled. So we will reach out to all of you when we have updates through this echo mechanisms. Thank you so much. And I really appreciate for all the questions and comments. Thank you.
Thank you very much, Dr. Sofonias, for the wonderful presentation. Also want to acknowledge all of you for coming through and asking so many questions. Again, so many questions to answer, which is proof that indeed this is an important subject and we need to work together to achieve more and eventually win the fight against the pandemic. There were also questions that included what is it that we can do to leverage what we are doing to solve other health problems that we have as well beyond COVID-19. Also a special thanks to Sarah, our language interpreter, for the wonderful work as usual. From the ASLM team, Africa CDC, PGI team, the Laboratory System Strengthening Community of Practice, LabCorp, it's a good afternoon, good evening, or good morning for those that are in the West. Goodbye.